Good morning, everyone, and welcome to the WellMed Charitable Foundation Caregiver Teleconnection. Today, we've got a very timely presentation called, of course, What to Know About the New Treatment for Alzheimer's Disease. And we have Dr. Elliot Montgomery Sklar presenting for us today. He's a public health professional focused upon supporting the health of the public through academic work, research, and service. He has led healthy aging programs for seniors and for caregivers in Canada and the United States and virtually on the net. Dr. Sklar is an associate professor of healthcare sciences at Nova Southeastern University in Florida, and he's a very busy guy. He publishes and presents his work internationally, which is focused on the complexity of issues related to aging and caregiving. Dr. Sklar, thank you so much for being with us today. We really appreciate you and all your knowledge and experience.
Thank you so much. I want to thank you for that intro, and also welcome to all of our participants. Thank you for taking time to be with us today. And really, we're here to discuss some very exciting news, actually pieces of good news as it relates to Alzheimer's disease and treatment. So I wanted to let you know what to expect for our time together today, because we're actually going to discuss two new drugs, one that is in the pipeline, should be approved by the end of the year, and another that was just approved last month. You may have heard of it, called Leqembi. We're also going to talk about diagnosis and disparities, because it's interesting to me that we still have no gold standard diagnostic test for Alzheimer's, and yet we are approving new treatments for something that we don't have a diagnostic for, much like depression if you think about it. But how Alzheimer's presents in the body is not consistent across all bodies. And so we're going to talk about that and what these new treatments mean in that context. And also, I want to empower everyone participating today with some things that you can do starting today to help improve cognition that has been clinically found to improve cognition and perhaps even prevent cognitive decline. So we'll talk a bit about that too. Lots to talk about. So last month, in very exciting news, the FDA approved the first drug shown to slow down Alzheimer's disease. The drug's name is Leqembi, whose generic name is lecanemab, if I'm pronouncing it correctly. These drugs are not easy to roll off the tongue. But the drug received what's known as accelerated approval from the FDA based upon its ability to remove the substance called beta amyloid from the brains of people in early stages of Alzheimer's. So full or traditional approval from the FDA, it is meant to signify that Leqembi also helps to preserve memory and thinking, which is actually what the drug was intended to do. So this is all very, very good news. Now, what's more important, I think, is that the Centers for Medicare and Medicaid Services announced that it would broaden coverage of Leqembi on the same day that the drug actually received FDA approval. Now, that should mean that the drug would now be covered for most Medicare patients with early signs of cognitive problems, but also having elevated levels of the amyloid that I was discussing. Now, in studies reviewed by the FDA, Leqembi appeared to slow declines in memory and thinking by about 27% after 18 months of treatment. Now, it also really reduced the sticky beta amyloid plaques that build up in the brain of people with Alzheimer's disease, which is believed to be the cause of Alzheimer's. Now, despite reducing the plaque, Leqembi is not something that's going to stop the disease or actually reverse it, but it may slow down progression of the disease and give people more meaningful time with their families and overall quality of life. Some experts have suggested that the medication could delay long-term care placement by about 6 months or more. Now, I'm not really sure how they arrived at that, since long-term care placement is such a personal and unique and subjective decision, but nevertheless, it's still a very hopeful and positive prediction. The FDA is prescribing that Leqembi is appropriate for people with early Alzheimer's, where there is elevated beta amyloid confirmed. Now, we'll come back to this because it says sticky points, no pun intended, since amyloids are sticky plaques. But the treatment was studied in people living with mild Alzheimer's and dementia due to Alzheimer's, and who showed evidence of the buildup of this beta amyloid plaque protein in the brain. The therapy has not been tested on people with more advanced stages of Alzheimer's or those without the beta amyloid presence. It's important, we'll come back to that. The treatment is administered every 2 weeks through an IV infusion, and that infusion lasts about an hour for each treatment. Now, typically these infusions are done at infusion therapy centers or in hospitals, and we're seeing more of these infusion therapy centers coming about because more drugs are being administered in that way. So now that the drug is approved, ramping up manufacturing and nationwide distribution, all of that's going to take a little bit of time. I wanted to answer some commonly asked questions. People have asked me these questions. So I'm going to share what we know from the studies on this medication. And then I want to open it up to you to discuss and see what questions you have. If you remember last year, there was a drug called Aduhelm that was approved by the FDA. And the major issue with that drug was that it was so expensive and it was not as effective. And so CMS, for example, Medicare, Medicaid, they did not cover the cost of the drug, which was about $56,000 or $57,000 a year. In addition to that, you have to also consider the cost of getting these scans in the brain to make sure that there are no brain bleeds, that the amyloid is actually reducing, which are also quite expensive. So the most common side effects with these drugs were infusion-related reactions, but also, as I mentioned, bleeds, swelling, headache, brain swelling are very common. And so in order to be eligible for treatment of Leqembi, it would require an initial test to determine amyloid levels in the brain, because it has only been approved for people that have these specific amyloid levels, and then periodic brain scans to detect side effects. So still a very expensive proposition. I believe this drug costs about $26,000 a year, half of what Aduhelm roughly costs. And as such, it's exciting that it will be approved, but I think it's so important that people speak with your own doctor to discuss the potential for this medication, because people's amyloid levels are different. Some people may not even know what their amyloid level might be. And so it's important to also weigh the risks and benefits, because as I mentioned, in rare cases, the drug can cause brain bleeding and swelling, just like its predecessor, Aduhelm. But in this case, because the effect was so powerful in the study that was conducted, in terms of the benefits here, many doctors are saying the benefit outweighs the risk. I've spoken with a couple of geriatricians locally here in South Florida who are cautiously optimistic. And I see that we do have a message in the chat from Rebecca. So this medication will not be good for people taking anticoagulants. That's an excellent question. One that is not actually addressed in the clinical study. But one would think that if a drug causes brain bleeds, you would not want to be on an anticoagulant. So that makes perfect sense. And again, something that I would suggest that you speak with your doctor about. Rebecca also asked, does the amyloid have a specific name or test that the person will need to request with your doctor? Great question. I'm going to talk about that. So Leqembi does require an initial test to determine amyloid levels in the brain. And as I mentioned, also periodic scans to determine how the drug is impacting those amyloid levels, and also to determine if there are side effects. Now, one of the challenges is that it's going to take time for the US healthcare system to be able to adapt. We don't typically test people for amyloid levels in the brain. It's not very common. And I'm going to talk about those specific tests. But Do we have enough imaging centers? Do we have enough technicians to be able to do this? We have a large number of Alzheimer's patients, and it's going to take our healthcare system some time to adjust. Now, in most of the medical journals and press that I've reviewed ahead of today, and I will circle back to that testing issue because I'm going to talk, as I mentioned in our agenda a little earlier, I have a section where I'm going to talk about testing and detection and why I think we need to think more critically about these new treatments, because if we don't have a gold standard test for something, what exactly is it that we're treating? Much like with depression. Most of the medical journals and press that I've reviewed ahead of today seem to have a lot of support for Leqembi, much more so from doctors and also from payers than its ill-fated predecessor, Aduhelm, which, as I mentioned, had also removed amyloid from the brain. Now, what remains unclear is whether Aduhelm, the previous drug, slowed down loss of memory and thinking. It didn't really show that in the research. And so doctors were kind of hesitant to prescribe it because, again, the side effects can be significant. And we didn't have a good risk-benefit scale for that medication. In this case, the cases of brain bleeding and swelling seem to be less with Mckembi, and the effect on memory seems to be better. So as such, that's why, for example, Medicare is covering the drug, which until this point only covered it for people in certain clinical trials. So private insurers, however, like Blue Cross, have said just a week or two ago that they will not cover the drug because of the high cost and, according to them, limited benefit under this accelerated FDA review. So this should be a really interesting issue to watch play out, I would say, because it's interesting that Medicare is setting the precedent here in terms of coverage. It's going to be hard for private insurance companies to deny coverage if a patient meets the criteria for treatment. So the whole point here is that people who are in the early stages of the disease will have access to the drug and also will be able to afford it, which is not an option we had before. And as we know, many people under 65 develop Alzheimer's disease. So that cost that I mentioned of $26,000 a year, it's about half the cost of Aduhelm, which was approved in 2021, but it's still going to be financially out of reach for people if they don't have insurance to cover it. So again, very important to speak with your doctor to weigh the pros, the cons, and also to see if there is presence of amyloid in terms of whether or not your insurance will cover it. I am going to get to that detection and testing part of our presentation in a little bit, but I wanted to see if people had any questions about Leqembi, which was just approved based upon a very large clinical trial.
Okay, folks, this is your opportunity to ask us some questions. You can go to the chat room, you can unmute yourself, put your hand up. We would really love to hear from you. I have a little website where I can see if you have unmuted yourself. It looks like Robert Day has unmuted himself. Would you like to talk to us? Robert? Okay. He's unmuted, but he doesn't want to talk to us. Oh, Rebecca has a chat for you.
Sorry, I was on mute. Rebecca asked, will they require prior authorization since there is a lot of Medicare HMO companies? Excellent question. I will get to that when I talk about the testing and detection too, because my suspicion is that this is going to be a little bit of a hurdle for people, even if they do get insurance coverage. There are so many particularities in terms of being able to qualify for this treatment based upon the amyloid. And that is a concern that I have about this medication and the direction that these medications are taking. And we're going to talk about that. I saw also, Gloria, you were unmuted. Is there something you would like to share?
Okay, Gloria and Robert, I'm going to put you on mute so that I know next time whether you want to talk to us or not. Okay, Gloria?
I'm going to keep going, and if things
Okay.
come up, feel free to post the chat. I do see we have another question from Julia. Is it given through regular IV or a special implanted port like an infuser port? Excellent question. The study, the clinical trial, was based upon administration through a regular IV. However, different infusion centers may want to use an implanted port because, as I mentioned, this is something that you would need to have an infusion every other week. So that's quite frequent, more so than for other medications for which infusion therapy is currently being used. Great question. And these are a lot of things that are not discussed in the clinical trial. So again, this is a very interesting change for the FDA. It's almost akin to our COVID vaccines in terms of the expeditious timeline and data with which they have rendered this decision because of the number of people who have Alzheimer's disease and the fact that we don't have viable treatment options. There are a lot of unanswered questions, a lot of questions I had from reading the evidence with which the FDA rendered this decision. And that is also why I want to talk to you all about another drug that you will hear about later this year, but I hope I'm the first to bring it to your attention because it's actually been found to be more effective than Leqembi, and I think it will be a better option for some people. So let's talk about this other drug, which right now does not have a brand name. The generic name for it is Nanomad. Again, doesn't really roll off the tongue. But in a study of more than 1,700 people, this experimental drug slowed the progression of Alzheimer's by 35%. So that's 8% more than Leqembi, and it may receive FDA approval as early as December. This is the biggest clinical effect ever seen in any Alzheimer's trial. So that's very significant. But to me, the part that is most significant about this drug is that patients were taken off of the drug once the plaques in their brains were mostly gone, usually within about a year. So this isn't something that you need long-term treatment. It's kind of like, you can think of it almost as chemo for Alzheimer's disease, something you do short-term and have better quality of life following. What was found was that the plaques did not reappear in the 18-month study that was conducted, and there is tremendous benefit to thinking and memory, which continued even after treatment ended. So it is important still to keep in mind, these medications work in a similar way. They target amyloid. They also can cause dangerous swelling or brain bleeds. In the study of this drug, brain scans revealed the side effect in about 25% of patients. That's considerable. 6% of them had symptoms like headache, nausea, and confusion. And I see a question from Rebecca. Will they have to be monitoring members' blood levels regularly to ensure blood is not thin that can lead to bleeding? Excellent question. It was not indicated in the clinical trial. Other tests are, but not tests with regard to blood coagulation. So it's an excellent question. And is this a pill or another infusion? It is another infusion. The results were published in the Journal of the American Medical Association, and they do suggest that this drug is more effective than Leqembi. And it's amazing how they came out just one right after the other. It's the biggest effect, as I said, ever in an Alzheimer's trial. So if you want to start investing in Eli Lilly, just kidding, they're the manufacturer of the drug. But they're expecting a decision from the FDA by the end of the year. So again, this is not a cure. It is very similar to Leqembi, and the medication can help to delay disease progression. Now, this study particularly focused on people whose brain scans rather showed plaques and other changes associated with early Alzheimer's. They had only mild cognitive symptoms. And the study also suggests that most patients may not need monthly intravenous infusions for life, as I mentioned. The other good news, it's a monthly infusion, not a biweekly. Patients, as I said, were taken off of the drug. They did not need to go back on it. Now, both of the drugs, as I said, are very, very new. I think we have a lot to learn about them. But I think that this kind of treatment that might not require long-term treatment might be more financially viable, might be more accessible to people. And certainly the study's efficacy shows a better slowing of progression of disease than Leqembi. See, we do have another question here. Will an MRI be required after the 5th, 7th, and 14th infusion to assess for brain bleed swelling if it has the same risks as Leqembi? Love that question. Clearly, you've been reading up on this. So I'm going to talk about detection and about testing because it seems to be a question that a lot of people have, and then we'll open it up for some discussion. So a concern that I have with regards to both of these drugs, and I think we can all agree that when it comes to any disease, really early detection is extremely critical, especially when medications and treatments are meant to be most effective in treating early stages of a disease. So there are some tests for genetics that are linked with a predisposition for Alzheimer's disease, but that does not at all mean that a person will develop Alzheimer's disease. And in fact, healthcare professionals advise against this kind of genetic testing and only use it to help confirm a diagnosis of Alzheimer's. So right now, there is no single FDA-approved diagnostic test that can determine if a person has Alzheimer's disease. Now, this is interesting if you consider that the FDA is approving medication, very expensive medication, used to treat something that it hasn't approved a detection test for. So what type of diagnostic test is the FDA requiring in these approval processes for these medications? And by the way, these are the same tests that a physician would need to use to continue to monitor patients who are receiving either of these treatments to assess the plaque level in their brains and also if swelling or bleeds are occurring. So physicians are using a variety of approaches to help make a diagnosis. They may use medical history, mental status tests, physical and neurological exams, but physical exams like biofluid taken from cerebrospinal fluid and blood tests, as well as brain imaging, before initiating any anti-amyloid treatment, the prescribing information requires that a physician confirms the presence of beta amyloid plaques. The FDA does not specify a diagnostic tool to determine elevated beta amyloid plaques, but tools such as amyloid PET scan or lumbar puncture tests are examples, most commonly a PET scan. And that would be as well something that would be continuous during and potentially even after treatment. So I hope that helps to answer some of the questions people had about testing. I do see another question that patients that were in the other trials who had brain bleeds, can they still try Leqembi? Yes, brain bleeds do resolve on their own when a patient is taken off of the medication. It is something that you would need to speak with an individual provider about because, as I said, all of these decisions are so unique and so specific. A physician might want to refrain from prescribing a drug if a brain bleed occurred previously. It would be up to a physician to really discuss that with the patient and to evaluate specific risks and benefits. We're not looking at a medication that has, let's say, an 80% improvement rate, which would make it much easier to make that kind of a decision, right? Because if you have a really great chance that this medication is going to completely improve your quality of life and memory, then that might make it more worth it. But if we're looking at a maximum of 35% improvement, then that's going to require some more decision making, I think. Any other thoughts or questions that people might have about this? To me, this is a very controversial issue, and I think something worthy of us really thinking about as we evaluate these type of treatments, and also who is eligible for these type of treatments.
And it seems like our participants today are pretty well read in terms of what's going on in all these new treatments, which is how we got all these great questions. So thank you very much.
This is better than most of the graduate courses I teach. So A plus for all of you today. And I really do appreciate these questions. They're excellent questions, ones that I've had as well in just reviewing this information. As I said, we don't have a lot out there to go by. I have read the clinical trials for each of the drugs. The information is very interesting, but as I said, a little controversial. And we're going to talk a bit about the concern I have about people's being eligible for these type of treatments. And are we really creating treatments that are a one-size-fits-all or one-size-fits-some? Minerva had a great question. Do insurance companies cover the PET scan and the lumbar puncture? Excellent, excellent question. It depends on individual insurance. I can say right now for Medicare, because Medicare is willing to cover Leqembi and they require that these tests be present in order to prescribe, they are covering it. But private insurance companies, this is a very hot topic issue. And it's going to be interesting to see what they do cover and what they don't cover. And a concern, as I mentioned too, is that what about people who are under 65? We know that Alzheimer's, sometimes there's early onset Alzheimer's disease. And if a person is under 65, will their individual insurance cover it? People might really have to advocate. I think, again, the fact that Medicare has paved the way here sets a precedent, and it's going to be hard for private insurance companies to get away without covering what Medicare would. But time is of the essence here, right? So how long do people want to be fighting their insurance companies when they should really be getting the treatment if they need it early on? So I want to talk a little bit about what it is that we're actually treating. Seems like we have a group of people here who know a lot about the amyloid hypothesis, that amyloid plaques are what are the cause of Alzheimer's disease. And that has been a theory that a lot of researchers and scientists have been working with a long time. And the results from both of these drugs provide strong evidence that removing amyloid from the brain can slow down Alzheimer's. And as I mentioned, that approach is known as the amyloid hypothesis. But again, it has been a very controversial hypothesis because there have been dozens of other amyloid drugs that failed to help patients with no kind of clinical benefit. So scientists still aren't very sure which forms of amyloid offer the best target. And the results of these new drugs, I don't think are going to end that debate. Nanomad, the drug that I just spoke with you about that will be approved at the end of the year, hopefully, is designed to target plaques specifically, whereas Leqembi is designed to target other forms of amyloid, but also removes plaque. Both of the drugs seem to work and slow down the loss of memory and thinking in patients with early Alzheimer's. So this reminds me very much of how we treat depression. There is no FDA-approved test to to test for depression at present, but there are many FDA-approved treatments. They're widely prescribed. They don't all work the same way, and the effects people have are similar. We know that they work on a biological level almost immediately. For example, if you take a serotonin reuptake inhibitor, that reuptake inhibition occurs as soon as you start taking the drug, but people don't feel the effects of it sometimes for 6 weeks. And we still don't know why that is. So I think it's helpful to look at these things in a similar way because the brain is a mysterious thing that we're still learning about. Another question I have is how these studies quantified improvement of 27 and 35% respectively. Now, the studies measured plaques and proteins as well as used the clinical dementia rating scale to assess differences among study participants. So these reported improvements reflect a combination of reduced plaque and amyloid in addition to a cognitive assessment. But the thing that we don't know is how these people's diseases might have progressed without the treatment. So to say that there was a 35% or a 27% slowing down in the progression of the disease, do we know how the disease might have progressed without these treatments? I don't think that we really do, but if they work, I'm all for it. I just think that these are things that are important for us to consider because we're learning a lot still about the brain, and there is a lot that we don't know. I wanted to know, please, Evelyn.
Was this a double-blind test or a clinical trial?
It was a clinical trial. Half of the participants received a placebo and half received the medication.
And they didn't know which?
No.
Yeah. Thank you.
So, yes, of course. Any other questions? All right. Well, I'm going to move on to what I think is the most controversial part about all of this. The fact that these medications are not a drug that works for everyone. And this is something that has not made any headlines about any of these new drugs. It's a concern for me personally. These treatments work by removing a toxic protein, as I said, called beta amyloid. But that occurs to benefit white people more than Black Americans. About 20% of older Black people are estimated to have Alzheimer's disease or other dementia, twice the rate of white people, and above the rate of 14% of Hispanics. And although older Black Americans have twice the rate of dementia as whites, the study published on Nanomad in the Journal of the American Medical Association included about 90% white participants. I've highlighted that here in the box that I took specifically from the study from JAMA so that you could see for yourself that there were 88.8% white participants. And the study for Leqembi included about 76% white participants. So prospective Black volunteers with early disease symptoms did not have enough amyloid in their brain to qualify for the trials. Hispanics who experienced dementia, as I mentioned, at about 1.5 times the rate of whites, were also excluded at a somewhat higher rate due to low amyloid. So the growing evidence of a disparity around amyloid, a defining characteristic of Alzheimer's, is raising questions among scientists about who will benefit from these two new treatments, as well as who will qualify for these treatments. If, for example, these Black and Hispanic participants didn't qualify for the clinical trial, will they qualify for treatment? That is a concern. And maybe the reason that this did not make the news is that it's not really newsworthy, which is even more upsetting. Clinical trials typically have very low enrollment of diverse populations. Many people don't realize that. Across 96 dementia trials between 2000 and 2017, diverse populations only made up 11% of study enrollment across all of those studies in all of those years. But what is concerning is this eligibility criteria. And if we're finding that people of color don't have amyloid levels the same way that white participants do, how are we designing treatment options for people? And is there equity among that? So some experts are focused not on amyloids or plaques, but on other factors that might put groups at risk for higher risk of developing Alzheimer's disease or even other diseases. Now, as an example, in the United States, more than 75% of Black Americans are overweight or obese, increasing their risk of hypertension, high cholesterol, type 2 diabetes, sleep apnea. All of these are factors that raise the risk of vascular dementia. So socioeconomic factors play a role in obesity, but they might also then play a role in the development of dementia. So you might have heard that there is also an increasing link between depression and dementia, for example. So I think there are other things that we need to be looking at other than just these plaques and amyloids, because while it might be the case that they are responsible for the development of Alzheimer's in some people, it might not be as true for others. So I know this is a little controversial, but I wanted to invite your thoughts, your questions, any insights that you have. See, we have something in the chat from Donna. This raises the question, are amyloid plaques actually the cause of Alzheimer's or something else? Couldn't agree with you more. And that's why we're going to end our talk today, really talking about that and what it is that we can all do right now to perhaps decrease the odds of the development of Alzheimer's or even to delay disease progression. There are things that have been found to work that we can do. But I ask the same question, is the amyloid plaque really the cause then? And how will we know that if we're approving and looking to create medications that really only benefit one segment of the population? Amazing to me that this stuff doesn't make the news. Any other thoughts or any questions or concerns that anyone has?
Well, I think we're pretty lucky to have you with your mind going, how does this work? Is this doing the right stuff? And, it's so interesting to hear your perspective because of all the research you've done and reading the clinical trials. So thank you.
Of course. Well, that's why I'm here. I also used to teach in a medical school for about 10 years. And what I learned teaching medical students is that roughly half of the things that medical students learn during the course of their schooling will be proven incorrect over the course of their career. So what we need to be doing is teaching people how to think critically and how to be asking the right questions. And I've always made it my goal to ask questions of the research that is presented and to get people thinking, because if I was a patient and I was going to be evaluating whether or not I wanted to go on one of these drugs, it's important to know who comprised the study participants and are they reflective of the general population or not. And in these studies, they are not. They're also not reflective of the people who actually have the disease, and that's more concerning. So let's end on a really positive note, right? And engage some conversation. What can we do right now? So people with Alzheimer's disease and their caregivers who want to explore new treatments but are concerned with cost and access, you might want to consider enrolling in a clinical trial. There are several, and we're going to provide resources following our program today and in my list of resources on the next slide that can help you access clinical trials in your local area. Some of them are producing the data that we've actually spoken about today. Some of them included Leqembi, some included this other drug, and there are new ones still in the pipeline too. The Alzheimer's Association has a lot of information on a specific website as well that I'm going to share that includes a feature called Trial Match, which allows you to determine your eligibility for trials in your area. Now, this leaves me with a prescription that I have for everyone today that is FDA approved and shown effective in improving cognition upon multiple studies with racially and ethnically diverse populations. And that is simple exercise and nutrition. I say it all the time, but a review of published research evaluated the evidence from clinical trials on behavior and lifestyle changes to prevent or delay Alzheimer's or age-related cognitive decline and found encouraging evidence for 3 types of behavioral change. They included physical activity, blood pressure control, which can be achieved through physical activity, and cognitive training. So things like crossword puzzles, things that we already know help to keep cognition sharper. Additional research has suggested that regular exercise can positively influence cognitive ability, reducing the rate of cognitive aging, and even reducing the risk of Alzheimer's disease and other dementia. One particular study examined the effect of aerobics on memory impaired people and found that a 12-week exercise program improved memory over those who didn't enroll in the program. There's a study from 2020 that investigated the effects of the Mediterranean diet and aerobic exercise on cognition among people living in independent living facilities. It's called the LILAC study. And what they found is that after 6 months of a program that included the Mediterranean diet, exercise, and a combination of both, had a positive impact on cognition, mood, and also general health in older people living in independent living. And there was a significant improvement in spatial working memory performance in the combined group of exercise and diet, showing an overall improvement in their emotional state as assessed by the Depression Anxiety Stress Scale, more so than the exercise-only group, which was interesting. The research also indicated that diet and exercise do have the potential to improve aspects of cognition and mood in an aging population. Now, one of the challenges in any of this research related to diet and exercise is that if you improve cognition and you improve people's health, no drug company benefits. There's no money to be made and no reason to pay for clinical trials to examine these effects of exercise on diet and cognition, as an example. So we have no way to compare it to those clinical trials that I discussed today, boasting these reduced cognitive declines by 27 and 35%. Maybe exercise and nutrition can have a similar benefit. We don't know. Now, I'm a huge advocate of science. It's what I teach. But it's also important, as I said, to teach people how science works, especially in terms of clinical trials, of how research gets funded and paid for, and especially when those treatments cost about $26,000 a year. So I want everyone participating today to know that you can actually use diet and exercise to benefit your health and well-being now, and also potentially in the future. Lucy Barilak and I did a program earlier this year called Our Health is Our Wealth, and we're going to be hosting this series again this coming October. We talk about diet and exercise and how it can benefit cognition for caregivers, but also care recipients alike. If you've ever heard about the blue zones, it's something I've talked about before. It's the areas in the world where people live the longest, but also the healthiest. Netflix is actually coming out with a series, a documentary about these blue zones, because they have far lower rates of Alzheimer's and dementia, stroke, hypertension, a lot of the things that we're plagued with here in the United States for the most part. And the only blue zone that exists here in the United States is in Loma Linda, California. So very interesting to see the effect that lifestyle can have on our health outcomes. And I hope that today I've helped to illustrate some of the findings of these studies and answer questions, but also to tell you more about these treatments, particularly the one that's under review. I think the fact that it would not need to be taken long-term seems to be something more effective, especially when you consider that PET scans or MRIs with contrast might be things that people would need on a routine basis who are undergoing these types of treatments. There are a lot of roadblocks in the way in our current health system. So I think it's important that we focus upon what we can do right now while we wait for some better options. Now, I promised a lot of resources, and at the top here, these are all hyperlinks, by the way. So when you get a copy of the handouts, you can just click on the things that you see underlined here in this lovely dusty rose color. But at the very top, we have the link to help orient you to clinical trials in your area. I've also provided more information about Leqembi, about the medication that I've talked a lot about, Nanomad or Nanomad, waiting to see what wonderful name they come up with for the brand name of that drug. We also have some links here to information about the blue zones and the recording from the program that I mentioned that Lucy and I have done about how we can use exercise as an example to sharpen cognition. It's what they do in the Army. So there are techniques and there's research to support it all. And then there is a mental workout included here for you as well. I wanted to see if anyone has any questions. If anything stirred your thinking, please feel free to share it.
Not really a question, but I know that the more you read, the more you learn how fast all of this stuff is moving. And I know that AI has a part of that. Some of the things that they're suggesting might work or might not work, but it is going really fast and it's hard to keep up. So this was so amazing to get this from you. Oh, and Tanya agrees with me.
Thank you. And of course, as I said, we'll share these slides with everyone. Yes, research is moving really, really quickly, but we often just get like the Reader's Digest version on the news. Most of us probably didn't even realize that the participants of these clinical trials were majority white. And what are the implications of that for treatment in a diverse population? Will there be inequities in who gets treatment and who doesn't? To me, I think so, because if we're seeing that Black and Hispanic participants were excluded from trials because they didn't have sufficient amyloid levels, what does that mean even about the basis of their disease? Really echoing a lot of the comments that participants shared today.
And they're in the soup there.
Rebecca said, appreciate the information provided regarding this new medication that will help with Alzheimer's, of course.
Okay, folks, well, do we have another chat? Let me get them all. Okay, we got them all. I'm going to let you know about a few of our presentations for next month. But first, I want you all to know that you'll be getting your post-session questionnaire in a couple of days. We hope that you will take that seriously and give us, your feedback on how the presentation went today, any improvements that you might suggest, any presenters that you think might be good for our program. We really appreciate your input and want you to know that. And you won't get the resources or the post-session questionnaire unless you are registered. And I know sometimes people get the number or the link from somebody else. So if you're not registered, please get registered. Call our WellMed Charitable Foundation customer service wonderful person, Minerva, at 866-390-6491 and get registered. And then you'll also get this fabulous monthly calendar. Do you want me to answer that? We have some in Spanish, but certainly not. We have like one a month in Spanish. Okay. All right. So Elliot and Lucy, once again, next month are up for Engaging Caregivers, a program for healthcare workers. And what they're going to be talking about is this is really for people, and we've had such great participation from healthcare workers in these presentations. And it's really about defining caregivers and recognizing their experiences, difficult situations in elder abuse, and diversity in caregiving. So those will be, on Wednesdays, the 6th, 13th, and 20th during September. We have an additional 10 experts who are talking about topics that they are familiar with: coping with anticipatory grief, self-care for real people, brain health for older adults. Dr. Tam asks questions. She's like an expert in Alzheimer's disease. Toileting, incontinence, and dementia, and what you need to know with our dear Lucy. Disaster preparedness for caregivers, what to know with Elliot and Lucy. Healthy brain and healthy aging. Here's the Spanish one. Oh, let's see. Ideas about the basics of Medicare. Okay, I think that's what it is. Understanding and Managing Behavioral Symptoms with Lewy Body Dementia. Moving Away from Codependency with Dr. Jamie Heisman. And I have to tell you that all of these people are experts in what they do, what they present. They do the research, they're like Dr. Sklar, who's a scientist. And most of us are behavioral scientists. So it's cool to have him, who's kind of a combination of both. So I want to thank you so much, Elliot, for the beautiful job you did today. As always, and your critical thinking, example for us, because I think people are already doing that, as we saw, and it's great to support that and keep them thinking and working for us. I also want to thank all of our participants today, because they did such a nice job of, eliciting more information all the time, which makes the podcast so much better for, those who pick it up later, because you're living, with Alzheimer's disease. So it really matters that you share your questions and your comments with us. And I thank you. I also want to thank the WellMed Charitable Foundation for their generosity and supporting all of these different experts and their topics, and for scheduling them, and for all that they do for caregivers and their clinics and their SOS centers. And also that great website that we told you about, www.caregiverteleconnection.org. You go find out the topics that you're interested in, click on them and take a look at them, because there's some really good ones. Many have Dr. Sklar and our dear Lucy in them, and they're, just an example of how medicine changes, or science changes, Elliot. I have recently done one on the new science of brains. And I started out saying, when I went to school, we thought we were born with every brain cell we were ever going to have.
That's right. That's right.
So that's how fast, well, it wasn't fast because I'm really old, but things change a lot. So thank you all so much. And if there aren't any more questions, I'm going to go ahead and stop the recording so that Dr. Sklar can take over and provide personal support to anyone who'd like to have that. Is there any other questions? No? Okay, I'm going to stop the recording. Thank you all so much. Thank you, Elliot.
Thank you. Thanks so much,
you.
Evelyn. Likewise.